This conference will now be recorded.
All right, so my screen is visible.
Yes, ma'am.
Okay, so today in continuation of yesterday's lecture that was about the caries, we are covering the diagnosis and the management part of the dental caries. Now before going into that, we missed one part which is about the microflora. So what sort of bacteria is present in what kind of caries? So if you have pit and fissure caries, you will mostly find Streptococcus mutans. S. sanguis is mostly not found. Lactobacillus, so Streptococcus mutans and Lactobacillus are the significant species which will be found. Other than that, Actinomyces is also common. So if you have smooth surface caries, you will have Streptococcus mutans as the major bacteria present there. In the root surface caries, Actinomyces are the significant bacteria present. Other than that, Streptococcus mutans can be seen. And in the deep dentinal caries, Lactobacilli, Actinomyces, and other filamentous species are found. So pit and fissures. For the pit and fissures, Streptococcus mutans is the significant bacteria. Along with that, Lactobacilli and Actinomyces can be found. Smooth surface, Streptococcus mutans is seen. Root surface, Actinomyces species are seen. And deep dentinal caries, filamentous species, Actinomyces and Lactobacilli are seen. So which bacteria are common in root caries? Which bacteria are common in the root caries? Yes.
Sanguis and S mutant.
But your root surface caries, Actinomyces is common. Root surface caries, Actinomyces species are common. Along with that, Streptococcus mutans. See, when you have caries, Streptococcus mutans will be there. Now, depending upon the site where caries has occurred, predominant bacteria varies. If you have pit and fissure caries, Streptococcus mutans is the predominant bacteria present. Along with that, Lactobacilli and Actinomyces can be seen. In the smooth surface caries, Streptococcus mutans is the only predominant bacteria. In the root surface caries, Actinomyces species is the predominant bacteria. Along with that, Streptococcus mutans can be seen. And in the deep dentinal caries, Lactobacilli, Actinomyces, and other filamentous species are seen. Now coming on to the diagnosis part, diagnosis is basically the art and science which results from the synthesis of scientific knowledge, clinical experience, intuition, and common sense. So before going into the diagnosis, anyone can tell me what is specificity and what is sensitivity? Anybody who can tell me sensitivity and specificity? Yes, difference between sensitivity and specificity. At least please try. I'm here to correct you.
And specificity is to a particular area, and sensitivity is in general may include more than uh, 1 to 2 teeth.
All right. So I'll discuss this about this in detail. First, I'll tell you the ideal requirements. The ideal requirements of the diagnostic tool, it should be accurate, it should be sensitive and specific, that I will tell you now. It should be reproducible. So whatever time you repeat the test, this should give the same result. It should be reproducible. It should be reliable. It should not transfer the bacteria from the affected area to the unaffected area, and it should be cost effective. So there are some important factors to consider before deciding upon the diagnostic tool. Validity and reliability. The diagnostic tests must be valid and as reliable as possible. Diagnostic tests should normally show a kappa better than zero point 0.7 to be regarded as reliable. Sensitivity and specificity. The diagnostic test classifies individuals as having particular disease or not. Bearing in mind that diagnostic tests have inherent errors, the following decision outcomes are possible. So there can be true positive results, true negative results, false positive results, and false negative results. So what do you mean by true positive result? Yes. What do you mean by a true
Disease
positive result?
present.
Yes, that which true positive means if see if you are testing to find whether disease is present or not, true positive will give result will give you an indication that this disease is truly present. So if when the disease is actually present and you get the test positive, that is true positive. What is true negative?
Disease is not present, but symptoms are present.
But it's true negative. True negative means when you get the result as negative and also the disease is also not present. So true negative is when you get the negative result in the absence of the disease. So that is a true negative. See, like if you're testing for COVID, now patient is showing some fever symptoms, sore throat, loss of taste sensations, and all those things. If that patient goes for the COVID test, now if you get the positive result, that means this is true positive if the patient is actually having COVID. Now if the patient is having these symptoms and actually the patient is COVID negative and you actually get negative result, true negative. Patient was COVID positive, you got positive result, that is true positive. Patient was actually COVID negative, there was absence of the disease and you actually got negative result only, so this was true negative, which was in the favor. Now coming on to the false positive. Now with this example, tell me what is false positive.
No symptoms.
False positive is when patient is having no symptoms and still you got the positive result. When the disease is actually absent but still you got the positive result, so that is false positive. Falsely you got the positive result, disease was not there but you still got the result as positive. What is false negative? Yes, what is false negative?
When disease is present and the symptoms are also present, but the test result shows negative.
Yes, when everything is in a positive appearance, that is the disease is also there, the patient is also showing symptoms but still the test results were negative, that is false negative. Now coming on to sensitivity and specificity. Sensitivity, as you told me, sensitivity is actually it's a measure of how accurately diagnostic method is able to identify correctly individuals with the disease. So sensitivity is to determine a diagnostic test. How sensitive is a diagnostic test? It is determined by the measure of how accurately that method is able to identify individuals who have the disease. So when the disease is actually present and test is actually done and the test finds out the people who are positive for the disease, who are actually having the disease, so the test is sensitive. What do you mean by specificity? Specificity means how accurately diagnostic method is able to identify the individuals without the disease. So when the test is able to identify the people who do not have the disease, that is called specificity. Sensitivity is to find out people who actually have the disease, and specificity is to find out people who do not have the disease. So these two criteria are very important when you decide upon a diagnostic tool or a diagnostic method. So the efficiency of a diagnostic method is determined by its sensitivity and specificity. A diagnostic method should be able to find out who actually has the disease, and it should be able to find out who actually doesn't have the disease. Then coming to the threshold value. See, at times you don't get the, see, if for particular uh, test you get the value as 10, then for few diagnostic methods you won't get the accurate value. You might get a range of values, like from 5 to 10. So there is a range of values. So there is few diagnostic tools who do not result in simple presence or absence of the disease. Instead they give a scale of values, which is almost certainly, probably not. So these are threshold values, so below which and above which the disease will be either present or the disease will be not present. Now there is this iceberg concept of caries. Iceberg concept. So according to the iceberg concept, when up there is a tip of the iceberg that is visible to the eyes. However, there is a major part which is below the sea. If you see an iceberg, you are only able to see the tip of the iceberg, whereas there is a major part which is below the sea. So what do you mean by that? If you apply it to the caries part, that when the caries has reached the dentine or cavitation has actually occurred, then only you are able to see or evaluate that yes, the caries is present. However, the caries process has already started. It has well started from this part only. So it is very important for a diagnostic method to find out the incipient caries. That is, the early progress of the caries should be found out, so that the caries progression is stopped then and there only, and remineralization can occur, because once cavitation has occurred, remineralization is not possible. Then the interventions have to be done. So according to the iceberg concept, the tip which is visible is the clinically detectable lesion in the dentine, which is your D3 according to WHO, and D4 lesion which is into the pulp. However, beyond this, actually, either there is subclinical initial lesion which is in a dynamic state of progression and regression. If you are able to find it with a diagnostic tool at this stage only, you will be able to actually remineralize the tooth. Lesions which are detectable only with the traditional diagnostic aids, that is, radiographically you can visualize this. Clinically detectable enamel lesions which might have an intact surface. Then clinically detectable cavities which are limited to enamel. Here cavitation is to enamel, and here actually the dentine, and then the pulp is involved. However, our interventions start when we have reached this stage, but the probability, if there is high probability of finding the lesion at this stage, we are in a good position to control the caries. Now, assessment tools. Before assessment, there is assessment of the caries risk. There are certain things to keep in mind when you are determining the caries risk. Patient history has to be taken properly. Clinical examination of the patient should be done properly. Nutritional analysis of the patient is done. Salivary analysis and radiographic assessment. So these things should be done in a stepwise manner to finally assess the caries risk. So if you have a high risk patient and a low risk patient, what are the different factors which will vary according to the high risk and low risk? First, the social history. If you belong to a good socioeconomic background, the caries risk will be low. If you belong to a low socioeconomic status, the caries risk will be high. High risk in the siblings for those patients, and low caries risk in siblings for those patients. Knowledge of the caries is low when the patient is of a low socioeconomic status, and there is high oral hygiene and high dental knowledge for the patients who belong to a good socioeconomic background. Medical history. If there is no medical or systemic findings, then the caries risk is low. However, if the patient is medically compromised, yes, what are the systemic factors associated with caries risk? Yesterday we spoke about them. What is the major thing? What about systemic factors? What is the reason? If the patient is diagnosed with rheumatoid arthritis, what is the reason the patient will have high caries? Yes, anyone? If the patient is diagnosed with rheumatoid arthritis, what is the reason why the patient is having high caries risk? Yes? See, with the systemic conditions like rheumatoid arthritis, the patient will have low motor activity. And because of this low motor activity, the oral hygiene will be poor. Patient is not able to maintain a proper oral hygiene, and the caries risk will be high. Also, when conditions like your anxiety or depression, those diseases, then the patient is prescribed medicines. Those medicines lead to xerostomia. Then dietary habits. Yes, what about the dietary habits? How dietary habits influence the caries risk? Yes, please participate. How will the
Mm,
dietary factors?
more sticky foods and carbohydrate rich foods and
Yes,
sugary
yes.
foods will increase the caries risk.
Yes, more sugary food, more sticky food will increase the caries risk. Second point, what about the frequency? Type of food matters or the frequency matters? What about the frequency of uptake, intake?
Frequent snacking can also lead to caries.
Yes, frequent snacking will also lead to caries. Then use of fluoride. How will fluoride affect the caries risk? Yes, these factors have already been discussed. So I think you guys can contribute much better than me.
Fluoride decreases the caries risk as fluoroapatite crystals are formed.
Yes, very good. Fluoroapatite crystals are formed. So fluoride decreases the caries risk. In what manner, in how many ways do you one can get the fluoride?
Through water, through
Hmm.
dentifrices,
Yes,
mouthwash,
yes, these are all dentifrices. Then what through water also. Then what else?
milk,
Yes, milk, yes. In diet,
Salt in diet.
in diet, what all are the sources of fluoride?
seafood,
Yes, seafood and potato. Then plaque control. Plaque control, how does plaque control affect caries risk? It's written also, and I think it's obvious also. So tell me, plaque control. How is plaque control going to influence?
plaque, plaque contains bacteria
Yes. See there, the tooth, if this is your tooth, it is covered with a layer of plaque. So with this plaque and tooth interface, there is presence of this plaque fluid where all the exchange takes place. When the pH of your saliva decreases, the to compensate for that, calcium and phosphorus ions get out from the tooth to compensate for the hydroxyl ions, and therefore demineralization starts. So, however, if good oral hygiene is maintained, then the risk will be low. Then saliva, what is the critical pH of saliva?
5.5.
Yes, 5.5. What, when the pH goes below critical pH, what happens?
Increased caries risk.
Increased caries risk
Acid
because
dissolution.
yes, acid dissolution will start. Then clinically, if you see, a high risk patient will have some new lesions already present, whereas low risk patient will have no new lesions. Premature extractions will be there, no extractions in such cases. Anterior caries will be there. There will be sound anterior teeth. Multiple or repeated restorations would be seen. There will be hardly any restorations. No fissures, sealants would be there. Here, there will be proper fissures, which are the fissures which have been sealed so that there is no food retention. Multi-band orthodontic treatment might have occurred on these patients, which have led to the poor oral hygiene and therefore high risk. However, there in such cases, even if there are appliances, the oral hygiene has been maintained properly, and ideally there are no appliances as such present. So these were your caries risk factors, which are going to contribute to the risk assessment. So in okay, just a brief revision. Pitten Fisher caries, what all bacteria do you see? What is the predominant bacteria in Pitten Fishers?
Streptococcus pneumoniae.
Yes, S mutans and
Lactobacillus and actinomycosis.
yes, yes, root surface caries,
Actinomycosis.
yes, and
And S.
S,
mutans.
very good. Deep dentinal caries, deep caries,
Lactobacilli.
Filamentous bacteria.
yes, very good. Lactobacilli, filamentous bacteria, and actinomyces. What do you mean by sensitivity?
When a particular test is able to find out the
Diseased
Yes.
people.
disease is fine.
When the test is able to find out people who are actually having the disease. And specificity,
We're not having the disease.
who are not having
People
the
with
disease.
people
when
who
the
do not have the disease.
very good, very good. When the test is able to find out people who do not have the disease. All right. Then certain prerequisites for the detection and diagnosis. First, the tooth surface should be clean. If you feel like oral prophylaxis should be done before actually going for the diagnosis of dental caries. Why so? The tooth surface should be clean before actually going for a diagnosis. Why do you prefer the tooth surface should be clean? Why so? Some basic clinical knowledge.
Because, ma'am, the stains could appear as if caries. So, in
Yes,
order to, yeah.
and if that is so, if only by the appearance of stains you decide that there are caries, what kind of result could that be?
False negative.
False positive.
False positive.
Showing, yeah, because with the stains, you think yes, there are some caries present here. So you've seen the stains. So visually, just looking at the stains, you thought yes, there are caries, and you told the patient yes, there are some pits and fissure caries in your tooth. And although there are no pits and fissures, there were just the stains present over there, which could have gone by a simple oral prophylaxis treatment. So this is your false positive, that actually the disease is not present, but you got the result positive. So that is false positive. Other than that, there could be a plaque layer which is already present over the tooth. So you need to remove that plaque layer so that you are properly able to evaluate the tooth for your final diagnosis. Use of drying. Yes. How would this help?
To find out the incipient caries.
Very good. To find out the incipient caries, the other name for incipient caries is white spot lesions. Then so use of drying, you need to dry the area so as to evaluate the proper, because at times the plaque layer or the surface which is covered by saliva, that gives you a shiny luster, and you are not able to actually evaluate the proper surface. So you need to dry it, and because of drying you are sometimes able to see the white spot lesions also. Then sharp eyes and proper magnification should be there. Use of the probe. So actually, is it actually indicated for the clinical diagnosis? The probes, they should be actually used.
Ma'am, the state probes to see the catch point for caries.
Okay. We
But
do
ma'am, they
use
should
that.
not be used because the
Yeah,
microorganisms can be transferred from one,
very
and
good.
also it can, if it is in initial stages, it can also cause destruction in the area where we are checking.
Super. So actually, this has been told that we should use certain explorers and probes, and the sharp tips, they are moved over the tooth surface. And if you get a catch over there, you'll be able to find out, yes, there is some cavitation, and yes, there is caries present. However, this is now totally obliterated. The studies have shown that probing or the explorers in that form should not be used, because the pressure applied with the help of probe, that that might disrupt the superficial intact layer and lead to cavitation and progression of the bacteria. Also, because you are using the same probe for the tooth which has caries and the same probe for the tooth which is proper intact, then the bacteria might transfer from the one which has caries to the other which was completely normal. So you might, instead of actually stopping the progress, you might help in progression of the caries from one tooth to the other, because caries is an infectious disease. Okay, coming on to the infectious, what is MDS, MD? Yes, yesterday we spoke about it. What is the full form? MDS, MD? Something in relation to this infection, carious infection?
Ma'am, maternally derived streptococcus mutans disease, from when from mother to the child, the bacteria is transferred, so it causes.
Very good. So when the caries infection is transferred from the mother to the child, the patient, if the mother is high caries risk, there is high probability that the child will also be at high caries risk. And this phenomenon, this disease is called as maternally derived streptococcus mutans disease. Then there are certain clinical criteria to keep in mind. That is, you have intact surface, or you have a white spot lesion, or you have a discoloration over there, or there is some cavitation, or all in all the patient is having pain. So those clinical criteria have to be kept in mind when you are evaluating the diagnostic methods. Then there should be proper lighting. Then tooth separation. in case it is required. Radiography, proper radiographs have to be taken, proper angulation have to be followed. So what are the methods of tooth separation? Slow separation. Please enumerate few steps, a few methods of slow separation. Even all of you, if you say one step at least, we will complete the list. One by one, just keep telling me one step.
Plastics.
Yes.
Plastics.
Plastics. What plastics?
Elastics.
Elastics. Okay, sorry. Yes, elastics. Very good.
Crowns.
Okay. Oversized crowns. Yes. This is just a revision of your tooth separation methods. Slow separation and rapid separation. Slow separation will involve elastics, crowns, and
Thick rubber dam.
very good. Thick rubber dam sheets. Yes.
Wedges.
That's slow or rapid?
Rapid.
Yes. We're talking about the slow one right now. Orthodontic bands. Yes. What all is in the rapid? Wedges. Types of wedges.
Wooden. Plastic.
Yes. Further, basis on the shape.
Triangular. Round.
Very good. Other than that, other than
Light
wedges, what is?
light emitting. Light emitting.
Yes.
Light
Light emit.
transmitting.
Yeah, that is the type of wedges which are used in composites. Very good. Now, other than wedges, what is the other method for rapid separation?
Eliots separate.
Ferrier double bow separator. Okay. So this is before cleaning. See, you have a shiny luster over the tooth, but you are not able to evaluate whether there is proper cavity or not. So after cleaning is done, but the tooth hasn't been dried yet, then after cleaning and drying, you are able to evaluate some white spot lesions also. Also, you are able to evaluate if there is any cavitation here. So first method of diagnosis that we use is the visual examination, that you visualize it just through your eyes. This detection of the white spots can be done, or there is some discoloration, or if there is some frank cavitation. So this can be evaluated just by visually looking at it. Examiner detects the caries because there is change in the translucency of the enamel. So how is it that your caries part looks different from the normal tooth? This is your normal tooth, but your caries part looks different. There is discoloration, there is some white spots over here. Why is it so? What happens? Because of which reason the caries look different?
Due to destruction of appetite crystals.
Because of the destruction of these crystals, what has happened actually? The
Demineralization,
Even
demineralization of the
yes,
enamel.
yes, that is a Caries process. You guys are right. But what happens because of this Caries process that you are able to see the carious part different from the tooth? What is the end result of this Caries? The translucency of this sound tooth and the translucency of this carious part is different.
Due to
When you
acid
trans
dissolution.
Yes, because of this acid dissolution, the translucency differs. The tooth, the normal tooth has a different translucency, whereas your carious part has a different translucency. And because of this reason, when you put the light over the tooth, the sound tooth structure is able to transmit the light, whereas your carious part is not able to transmit the light, which is why the carious part is seen as dark area. Because of the change in the translucency, your carious part, the refractive index of the carious part changes, and because of this reason it is not able to transmit the light, and because of which reason this area is visualized as a dark area. Now, ICDAS, International Caries Detection and Assessment System, is given, which is an improved version of the visual method. So this has given some criterias. So after visualizing, you score the part, and accordingly, depending upon the score, the caries is decided. The extent of the caries is decided. This score was given by ICDAS, which is your International Caries Detection and Assessment System. International Caries Detection and Assessment System. So score 0 if you are visually able to see no or slight change in the enamel translucency after prolonged air drying, which is 5 seconds. So that is your score 1. Sorry, score 0. If you have some changes in the enamel, first visual changes in the enamel after prolonged air drying, that is your score 1, which is here. If there is distinct visual changes in the enamel, which is like this, see this white region, if you are able to see that after prolonged drying, then this is your score 2. Here drying is not required. Visually without any drying, if you are able to have a distinct visual change, then that is score 2. With the score 3, there is localized enamel breakdown that has occurred like this. The enamel spots have formed. Then underlying dark shadow from the dentine can be seen like this. This dark hue is visible. And distinct cavity, here the cavitation has properly formed. An extensive distinct cavity, here this is proper cavity which might have involved the pulp also. So these are the scores based on your visual examination. So by looking at the caries, when you reflect the light over them, just after looking at the tooth surface, if after prolonged drying, which is approximately for 5 seconds, if you see no or slight change, that is score 0. If you see first visual changes of the enamel, that is your score 1. If you see distinct changes and drying is not required, then that is score 2. With the score 3, there will be localized enamel changes or breakdowns that will be visible. If there is dentine discoloration which is seen, that is score 4. There is cavitation, small cavitations are there, and if the cavitation has increased or it has reached the full depth of the dentine or is slightly involving the pulp also, that is your score 6. So these are the scores by ICDAS. What is the full form of ICDAS?
International Caries Diagnosis and Assessment System.
Very good. So they have total of 7 scores starting from your score 0 to score 6. What are the disadvantages of your visual inspection? It is not reliable because you don't get, this is subjective, this is not objective. The caries depth cannot be visualized. Discolorations can be confused as caries. They can be mistaken as caries, even if the tooth is healthy. Then there are different methods of illumination. One is your visual light, which we just spoke about. Then instead of the visual light, you can also use UV illumination, in which the natural fluorescence of the enamel is decreased in the carious area. So the carious part and the natural tooth, this will have decreased fluorescence in comparison to the sound tooth structure, because there is less mineral content. So less fluorescence because of the less mineral content in the carious part as compared to the intact tooth. The carious lesion will appear as dark spots against a fluorescent background. This tooth will appear, sound tooth structure will appear as fluorescent, whereas the carious part in that area will appear as dark. If you illuminate this tooth with the UV light. Then ultrasonic imaging. In the ultrasonic imaging, the carious part is not able to reflect the waves, sound waves, the ultrasonic waves. These produce echoes with a higher amplitude. So cavitated lesions, the carious part will produce echoes with a higher amplitude, and you will be able to detect that. Then we have fiber optic transillumination, in which we use a fiber optic probe, especially in your areas which are least accessible. These can be placed in the buccal or lingual embrasures directly beneath the contact area between the two adjacent teeth. So if you have a caries, that will appear as dark shadow beneath the marginal ridge. The advantage is that it is non-invasive, no radiation hazard, and no permanent record is there. There will be no permanent staining. Fiber optic transillumination is used in the area where there is difficulty in placing the probe. So if you place the probe over this area, either from the buccal or the lingual embrasure, you will be able to see the cavitated part as the dark spot. Then we have DIFOTI, digital imaging fiber optic transillumination. It is similar to fiber optic transillumination. However, the final image is captured by your charged coupled devices, and then that is digitally analyzed with the help of computer, and you are able to diagnose whether the caries is present or not. So visual method. Why is visual method important? Visual method, with the visual method you are able to see without using any extensive method. It is non-invasive. You just by looking at the tooth surface, you will be able to diagnose whether the caries is present or not. But what are the disadvantages of caries method? Yes, disadvantages. Yes, disadvantages of caries method, in a visualization method.
Ma'am, proximal lesions can be there can be misdiagnosis.
Yes, the proximal lesions might not be visible properly. Yes, one. Second, they are not reliable, they are not reproducible, because your eyes anyways get fatigued. So after a while, you might think that this is just a stain. So these are not very objective. Then the stains, they can be misdiagnosed as caries. So yeah, the tooth might be healthy, but you have misdiagnosed the area as the caries. So then there is ultraviolet illumination. How your tooth the differs from the carious part when you are doing ultraviolet illumination?
Sound tooth shows more fluorescence
Yes, the
than
the fluorescence will be in the sound tooth. The carious part will appear as dark. Then ultrasound imaging.
Caries part shows higher amplitude echoes.
Yes, carious part will have echoes which have a high amplitude, longer wavelength lights, waves. Then fiber optic transillumination. And there is a fiber optic probe that is present, which passes the light through the buccal or the lingual embrasure. The sound tooth structure shows fluorescence, whereas your carious part will show as a dark spot.
Dark.
Yes. Then diphotai. What is diphotai?
Digital imaging,
Yes,
uh,
digital
fiber
fiber optic
optic.
transillumination. So digital imaging fiber optic transillumination, how is it different from fiber optic transillumination? The end image is captured by the charged coupled devices, which is then digitally analyzed with the help of computer, and you are finally able to make the diagnosis. Then we have clinical inspection. Clinical inspection or the tactile examination, that is done with the help of your probes and explorers. So types of probes available. Yes. First, difference between a probe and an explorer.
Probe has a blunt tip and explorer has sharp tip.
Very good. Probe has blunt end and explorer has sharp end. And probe has gradations, whereas explorer does not have gradations. Now, type of explorers. The one
Shepherd's
you,
crook.
yes, the most commonly used in operative is the one which has two ends. One is your Shepherd's crook number.
23,
Yes, and pigtail number.
17.
17,
Yes. However, as we already discussed, the use of probes and explorers is prohibited because one, they may transfer the bacteria from one tooth surface to the other, and second, the pressure might disrupt the intact surface layer and may lead to cavitation. Then coming on to the dye penetration method, there are certain dyes which are available, and how will we be benefited from the dye?
Infected dentin.
Yes, this will be with this we will be able to differentiate between our infected and affected dentine. And infected dentine will get stained or no?
Yes, ma'am.
The infected dentine will get stained, and we will remove the infected dentine, whereas your affected dentine will be left behind. So if you leave the affected dentine there, that is called as the process. This procedure is known as,
Indirect.
yes, indirect pulsing. So in caries diagnosis, qualitative examination is the prior requirement. Observation of colored dye signifies presence of caries. The dye should fulfill the following criteria. It should be absolutely safe. It should not be cytotoxic, or it should not be carcinogenic. It should be specific. What do you mean by specific?
should identify the disease.
should it should be able to find out the area where caries is not present. Specificity is the ability of a diagnostic method to find out the person who does not have a disease. Dye easily remove. It should be easy to remove, and it should not stain the tooth permanently. So enamel dyes, Procyon, calcine, brilliant blue. These are the dyes which are for enamel caries. Then we have dyes for dentine caries. Because your carious dentine, this has two layers. One is your infected, another is your affected. So it should be able to differentiate between the two, your affected and infected dentine. 0.3% basic fission in propylene glycol that is used, demineralized dentine with the collagen, which the collagen is stained. Inner one remains unstained, outer dentine is removed clinically, which gets stained. So that means your infected is stained and removed. Staining by the dye is the result of the denaturation of the collagen. So because your infected dentine has denatured collagen, which is collapsed completely, this will take up the stain and get stained, and therefore it will be removed. Basic fission dye, however, is carcinogenic and it has been replaced by acid red solution and methylene blue. Methylene blue to some extent is also toxic, so acid red is the most specific and the reliable one. Then there are certain modified dye penetration methods also available. That is your iodine penetration method, which works on the presence of enamel porosities. So they are able to find out even the incipient caries. Potassium iodide is applied for a specific period of time and it is able to give you a well-defined area of the enamel. Whatever excess is removed. The iodine, which remains in the micropores, is estimated and that indicates the permeability of the enamel. So the iodine uptake by the pores of the enamel is calculated and the extent of the caries is calculated as a result. So we have enamel caries, we have dentine caries, and then we have some modified methods of dye penetration which involves your potassium iodide. Tactile evidence, as I already discussed, explorers are there. Right angle probe, back action probe, shepherd's crook, cow horn with curved ends. Determine the roughness or softness of the tooth surface with the sharp explorer. Penetration and resistance to the removal of explorer tip, that is the catch has come. That is an indication that there is a cavity or demineralization. Probing, however, is criticized and is questioned these days because it may transmit the karyogenic bacteria and it may produce irreversible traumatic defects in the potentially remineralizable enamel. Mechanical binding of an explorer tip could be because of other reasons other than the cavitation. See, if you get a catch, you say it is caries. However, the catch could be because of other reasons as well. One, the shape of the fissure. If your fissures are more deep, you might get a catch. However, there might not be caries there. Then sharpness of the explorer. If the tip of the explorer is too sharp, you will get the catch. If the pressure applied while using the explorer is too much, then you might get a catch. Also the path of explorer placement. If you are placed in the path in the most retentive grooves, you might get a catch. So just by having a catch, you cannot diagnose that there is presence of caries. So along with the visual and tactile method, you require few adjuncts, which can be your radiographic method. So merely looking at the caries or merely by just exploring the tooth surface, you cannot get to an ultimate conclusion that there is caries or not, because these two methods, they are not, even if they are able to diagnose that there is presence of caries, they are not able to diagnose the extent of the caries. Now, tooth separation. Tooth separation is an adjunct to your clinical and radiographic examination. This tooth separation is mostly done to find out the proximal lesions. The method usually requires two visits, mostly at a period of 3 to 7 days, because once you apply what type of tooth separation is this?
Flow.
Yes, what is this? What is this which has been used here?
Elastic.
Yes, elastic method of tooth separation, which is a slow one. The limitation is that it requires second visit and it is discomfort causing to the patient. Then dental floss can also be used, which was given by Picard. If it shreds, one can suspect that there is proximal cavity. So you try to fit in the floss and then try to move it and pull it from the gingival to the occlusal surface. Now, if it shreds upon, the thread shreds upon, then there is a presence of proximal cavity. It is suspected. However, this might give a false positive result, because In few cases, there is proximal restoration present, and the overhangs of those restorations can cause the shredding. So they might give a false positive result that there is presence of caries. However, there is no caries present. Now coming on to the radiographic techniques. So we discussed about the visual methods. How many types of visual methods were there? Yes. Visual methods, please enumerate quickly. Please contribute. Please participate. Visual methods.
Ultraviolet
Yes,
transillumination,
ultraviolet transillumination,
sonic sound,
ultrasonic imaging,
Dye
fiber
penetration
optic,
method.
yes, photai and diphotai. Now, coming on to the tactile methods. Tactile methods, you use probes and explorers. Then you have dental floss method, tooth separation method. Then we have dyes, enamel, dentine, any dye of enamel, any dye which stains enamel.
calcium,
Yes, calcine.
Prussian.
Very good. Dentine,
red fusion, basic fusion,
basic fusion. Very good.
red,
Acid red, methylene
Methylene
blue.
blue,
Yes, methylene blue. Modified dye penetration method.
potassium iodide,
Potassium iodide. Very good. So now we come to the radiographic techniques. So in the radiographic techniques, what all types of radiographic techniques we have? The basic radiographic techniques. Yes.
long cone, short
Bache, paralleling technique and
Bisecting technique.
angle bisecting,
yes, bisecting angle technique and paralleling technique. What is in the paralleling technique? What is there in the paralleling technique? Yes, any idea? What is there in the paralleling technique? How do you place your sensor in the paralleling technique? The X-ray film, how is it placed?
When film and the tube both are parallel to each other.
When the X-ray film is placed parallel to the and the when the yes when the yes tell me yes. What did you say?
Ma'am, when the cone of the tube that is parallel to the film that we have placed in front
Very
of
good.
the tooth, they both are parallel.
Then how can that be achieved? Film holders are there. Bitable film holders are there through which we can achieve the paralleling technique. Which is better, paralleling technique or bisecting angle technique?
bisecting angle,
Are you sure?
Paralleling.
Paralleling is better.
And paralleling. Yes.
Yes, paralleling is better. What do you mean by bite wing radiograph? Bite wing.
When the occlusal surface of maxillary and mandibular teeth can only be seen in those radiographs.
Yes, that is placed between the maxillary and mandibular arches. Your film is placed between the mandibular and maxillary arches, and you are able to visualize the actual proximal surfaces. So where exactly do you require your bite wing radiograph? When you have to evaluate class 2 caries. So when you need to find out whether there is class 2 caries or not, and what is the extent of those caries, bite wing radiographs are very useful. However, there is a problem with the radiographs that usually there should be at least 40 to 60% demineralization that should have occurred in the tooth to be visualized in the radiograph. So we cannot visualize the incipient caries here in the radiograph. There should be at least 40 to 60% of the demineralization that should have occurred. IOPA primarily used for detecting changes around the roots and in between the teeth. Paralleling technique is superior to the bisecting technique. Visualization of approximately 3 teeth should be there in an IOPA. Bite wing can detect the incipient caries mostly at the contact points. 8 teeth in one radiograph can be visualized. Incipient caries, cervical margins of the restoration, alveolar crest height, and pulp chamber can be seen properly. Now, radiographic criteria of scoring: 0 if there is no radiolucency visible, 1 if the radiolucency is visible in the enamel, 2 if the radiolucency is visible in the dentine but only restricted to the outer third of the dentine, 3 if the radiolucency is extending to the middle third of the dentine, and 4 if the radiolucency in the pulpal third of the dentine. All right, so these are the scoring criterias according to the radiographic visualization. If you do not see any radiolucency, okay, first before that, if you have to visualize in a radiograph, the caries will be seen as radiolucent or radio opaque. Caries
Radiolucent.
are,
Radiolucent.
yes, radiolucent. So if you are not able to see any radiolucency, that means there is no caries. The score is 0. If radiolucency is visible only in the enamel, then the score is 2. If the radiolucency is only visible to the outer 1/3 of the dentine, then it is 2. If the radiolucency is extending to the middle third of the dentine, if it is 3. And if the radiolucency has reached the pulp or the pulpal third, then it is 4. According to ICDAS scoring, what is 4? Score 4.
Dentine
Ma'am,
discoloration is
the
visible.
hue of, yes, ma'am. When dentine hue of the caries can be seen,
Yes,
dentine gets
when this
affected. Yes.
very good, very good. When discoloration, dentine discoloration is visible through the dentine, that hue is visible. That is ICDS scoring 4. Good. Now, what are the problems which are encountered with the radiographic method? One, we have proximal contact, so there might be overlapping, so we won't be able to see that. There could be gagging sensation. Few patients are not able to cooperate because of the gagging problem. Then we might get false diagnosis because of the overestimation. There is increased lesion depth, but that is not visible because we have a different angulation. Radiolucency cannot be judged because of the caries or whether it is resorption there. Superficial demineralization, buccal and lingual surfaces imaged proximal caries. Cervical burnout, few cases you get a false. If you see, sometimes you confuse your cervical burnout with the caries. So what kind of result is that? True positive, negative, false positive, false negative.
False positive.
False positive.
Positive.
Yes. So what is cervical burnout? This is an apparent radiolucency which is found just below the CEJ because of the anatomical variation or a gap present between the enamel and the bone which is covering the root. So they mimic as root caries, but they actually are cervical burnout because they are also seen as radiolucency. Now, posterior cervical burnout and anterior cervical burnout. Posterior cervical burnout appears because of the invagination of the proximal root surface, which allows more X-rays to pass through it. Whereas your anterior cervical burnout is because of the space present between the enamel and the bone. And this space that causes the transmission of the X-rays and is visualized as radiolucent. So this was all about your radiographs. Two types of radiographic techniques, paralleling and bisecting. Paralleling is better in comparison to your bisecting angle technique. And how much of the demineralization should have occurred to be visualized in the radiograph?
40 to 60%.
Yes, 40 to 60% demineralization should have occurred. Then bite wing radiographs are superior as compared to your normal IOPs because you get to see the incipient or the proximal lesions quite clearly. Then there are certain disadvantages of radiographs. One, you are not able to see the actual extent of the caries. You won't be able to see the incipient caries. At times you get the false positive diagnosis because of the presence of cervical burnout. Now coming on to zero radiography. What do you mean by zero radiography? What do you, according to you, what could be the technique here? Zero radiography.
Xerox radio.
Okay, good try, but sorry, it is wrong. What else? What else? See, zero. What do you mean by this? Xerostomia?
Dry mouth.
Dry. That means there is no salivation or no fluid. Yes. So zero
Yes, ma'am.
radiography means by that we are not using any sort of liquid like your developer, or we are not using the fixer. So no solutions we are using here. So there is no, we don't have to develop the X-ray which we are going to get. The image needs not to be developed. We will have certain processing units which will convert our image into the positive image. So zero radiography, there is no solutions required as such. So it consists of aluminium plates which are coated with selenium, which have the electropositive charge, electrostatic charge. Now the X-ray film, X-rays are projected over the tooth surface. Then they are captured by the selenium particles. These selenium particles, they selectively discharge and the latent image is formed. This processing unit converts the latent image into the positive image. There is good edge enhancement in this technique, that you get a proper differentiation of the areas with different densities. You are actually able to differentiate between the enamel, dentine and pulp. Twice more sensitive than your D speed films, but equivalent to E speed films. So D speed films and E speed films are the variety of your X-ray IOPs. Disadvantages: electrostatic charges may cause patient discomfort. Because of the presence of these charges, the patient might feel discomfort. The process needs time, 15 minutes more. Expensive. Exposure time varies according to the thickness of the plate. So what is zero radiography? Zero radiography is actually an aluminium plate which is covered with selenium selenium coated particles. These particles are electrostatically charged. When the X-rays fall on them, they get discharged and leads to the formation of latent image. And this image is converted into the positive image. Modified radiographic techniques. One is your digital enhancement. Radiograph is recorded digital. Whenever the word digital is there, there is something related to the computer. You need to digitalize it. Now radiograph is recorded, digital image receptors record them, and that is enhanced and computer processed. The digital image is formed and represented by a spatially distributed set of discrete sensors which are known as pixels. Receptors, highly sensitive sensors, less radiation exposure than the film. It is the image that has been recorded with the non-film receptor. So you have a sensor, the X-rays fall on them, the sensor records the image in the form of pixels that is stored in the computer, where the computer processes these pixels and the image is formed. So there is no film required. The receptor is non-film receptor. It's actually a sensor. two types of non-film sensors or receptors are there. One is your digital image receptor, other is your PSPs. So digital image receptors, which includes your charged coupled devices, they are connected to the computer. This is actually a semiconductor. They consist of silicon oxides, which that is coated with X-ray sensitive phosphorus. CCD is sensitive both to the X-rays as well as the visible light. So we have a sensor inside the patient's mouth. The X-rays strike on them. Light photons are produced, which are detected by the charged coupled devices. This image is then stored in the computer and ultimately processed and then displayed for viewing. Indirect receptors, they are photostimulable phosphor plates, PSPs, photostimulable phosphor plates. So when X-rays interact with these phosphors, latent images indirectly formed, and then these plates are then transferred and inserted into the scanning device, and then they are scanned, images formed, processed, and ultimately the image is stored in the computer. So here there is a catch, and that is that in the direct there was charged coupled devices which directly transferred the image to the computer. Where PSPs, they store the image as latent image, and then these PSPs, they are scanned by the computer, and then image is processed and then displayed for visualization. Now, what are the advantages? One, there is no processing, so darkroom is not required. Instant image can be visualized. The quality of image is consistent. Elimination of the hazards of film development, so there is no solutions. Radiation dose is decreased. Capabilities for teletransmission, so you can transfer the image from one computer to another. Disadvantage, it is expensive because of the involvement of the sensors. These sensors are too sensitive, so you have to be very careful. Life is short. Detection of the occlusal caries performed almost equally well. No value in detection of initial enamel lesions, so they are also not able to detect the incipient lesions. Then coming on to the computer image analysis. Okay, before that, tell me, what do you mean by zero radiography? What is the technique for zero radiography?
in which solutions are not involved.
Yes, what is the technique? That is the literal meaning. You don't have to remember that. What is the technique actually? Zero radiography. What sort of plates are present in zero radiography? Yes. What kind of plates are there? Aluminium plates are present, which are coated with which type of particles?
Selenium.
Selenium particles. Now they get discharged and latent image is formed, and the processing unit converts this latent image into the positive image. So then coming on to your digital imaging. Digital imaging is of two types. What are the types? Types of digital imaging?
Digital image receptors.
Depending upon the receptors, they are of two types. One is direct, other is indirect. What kind of receptors are present in the direct? Charged coupled devices. And indirect? PSPs. What is the full form of PSP?
Photostimulable phosphor plates.
Very good. Now computer image analysis. In this, you get the image and that is stored in the computer. The computer already has similar images. The computer by itself analyzes your image and gives you a diagnosis. So clinician enters the patient's data. The computer program compares this patient's data with the basic knowledge of the pathology, and then program gives us the diagnosis. So you are depending upon the computer software for the diagnosis. The technique is also based on the expert system. Advantage, it provides a sensitive and objective observation, possible to monitor the lesion also. Quantification of small lesions is possible, but disadvantages always need standardization of exposure. Geometry sensitivity is higher, but specificity is less. It is time consuming and less economical. Then subtraction radiography. Subtraction radiography, it actually based on the principle that your unchanged anatomical background can be cancelled, which is also known as structured noise is reduced. What do you mean by this structured noise is reduced? That means to increase the detectability of the changes in the radiograph, the structures which are of less importance, they are cancelled. These are the images which are not of diagnostic value and they interfere in the interpretation of the radiograph, so they are subtracted. Disadvantage, there is inability to produce correct projection geometry, improper density and contrast. See, you are not able to actually get a proper image. Then cone beam computed tomography. This actually, in this we get several series of cross-sectional images which are then combined to get a 3D image. The basic disadvantage of your radiographic method was that your three-dimensional image, that is your tooth, is seen as two-dimensional image. So you do not get the actual extent of the caries. So cone beam computed tomography gives you a 3D image with the help of a series of cross-sectional images. CBCT gives you a three-dimensional imaging system, 3D system. So there are few slices which are viewed for radiolucencies, specifically useful for the detection of recurrent caries. CBCT utilizes least amount of radiation. Radiation dose is actually 1/4 that of the one which is required for IOPA. Now coming to the electric measurements for caries. In the electric measurements, actually after the tooth demineralization, there are porosities in the tooth structure. These porosities contain fluid. This fluid actually conducts the electric current. So this leads to decreased resistance or impedance. So that is the technique behind this. So when caries occur, porosities are formed. These are filled by fluid. This fluid conducts the current. The resistance for the current is decreased. Therefore, electrical measurement gives you signals to identify whether caries is present or not. It uses fixed frequency 23 Hz alternating current, which measures the bulk resistance of the tooth. So sound tooth structure will resist the current, whereas your carious part will not resist the current. So you will be able to find out whether there is caries or not. Two systems are there, Vanguard system and Caries meter L. Vanguard uses current of 25 Hz, whereas Caries meter uses current of 400 Hz. So you get four colors. One is green, orange, yellow, and red. Green is no caries, orange is dentine caries, yellow is enamel caries, and red is pulp involvement. So this is basically, if you see the color, what is the color of your rainbow? What is the short form to remember the colors of the rainbow?
Vibgyor.
Vibgyor. So it is gyor. Green, yellow, orange, and red. Green is no caries, yellow is enamel caries, orange is dentine caries, and red is pulp involvement. Factors affecting electric measurement: porosities, surface area, thickness of the tissues, hydration of enamel, temperature, concentration of ions in the dentin tissue fluid. Now, quantitative laser fluorescence. This is a quantitative assessment. There is irradiation of the visible light spectrum, which is mostly your blue-green spectrum. tooth, normal tooth structure, that will show fluorescence, whereas your carious part will be shown as your dark spot. Fluorescent filtered images are visualized on the CCDs, the charged coupled devices, and that is stored in the computer. Clinical implication, clinical trials, patient education, preventive clinical practices, they are used in these fields. It also monitors the demineralization of dentine. Early secondary caries beneath the restorations can be visualized at a great rate. Incipient lesions are detected. Sometimes red fluorescence porphyrins indicate presence of dental biofilms or high caries activity. Quantification of the enamel lesion, you can visualize the depth. Limitations, cannot discriminate between enamel and dentine lesions, and it cannot differentiate between whether it is an incipient caries or hypoplasia. Diagnodent, it is a modification of your quantitative fluorescence only, which uses red light instead of blue-green light. This light is partially re-emitted as near-infrared fluorescence. The device captures this fluorescence and translates into numerical values of 0 to 99. So depending upon the score, you see, so the light reflected is captured, and then signals are produced, and scoring is done from 0 to 99. So this is the scoring. 0 to 13, tooth is without dental caries. 14 to 20, it reflects enamel or dentine caries. 21 to 29, it correlates with enamel and dentine caries, that there is presence of the caries, and over 30 is definitely dental caries. Diagnodent pen is actually a compact system of your diagnodent system where it can be used in the interproximal caries. Caries scan. This offers the earliest possible detection of the caries. It's a unique device which gives you an accurate result and repeatable results. It utilizes the alternate current. The impedance of the healthy tooth is high because of the relatively low ionic conduction, whereas for your carious part, impedance will decrease, and that is visualized by the caries scan. As a tooth demineralizes, pores increase. These pores connect and the tooth becomes a mix of high and low conductive parts, and impedance decreases. As the decay progresses, dentine is involved, impedance further falls away. So the score also decreases. 0 to 100 scale is there. 0 to 50 is the low probability of caries. 51 to 90 is there is medium probability, and above 90 is the high probability. This is used to detect the early and the hidden lesions. What do you mean by fluoride bombs? Yes, fluoride bombs. Hibernation of dentine. Where do you see hibernation of dentine? Yes, where do you see hibernation of dentine?
Sclerotic dentin.
Arrested caries, bacha. Arrested caries, you see hibernation of dentine. Advantages, there is for this caries scan, there is highest proven accuracy of all caries detection methods. There is no ionizing radiations which are required. These are easy to record and compare progress. Contraindications, patients with cardiac pacemakers, because we are using alternating current. So we cannot use in such patients. It is not able to diagnose secondary caries, integrity of restoration, or root caries. It should not be used when the tooth surface has plaque or other debris, because they will conduct the current and will give false positive results. Then coming to the karyogram. Karyogram is used to assess the factors which contribute to the development of caries. This is actually a pie diagram. The green color gives the estimation of the chance to avoid caries. Dark blue color says that diet should be controlled. Red color that there is bacteria involved. Light blue color, susceptibility, combination of fluoride program, saliva secretion and buffering capacity. And yellow, circumstances like your past caries experience or related disease if any present. So basically karyogram is used to show the factors which have caused the caries, and these are the different colors which indicate the different factors which are associated with caries. Now, if we talk about the caries progression, there is bacteria biofilm and there is carbohydrate. That bacteria acts on the carbohydrate, acid is produced leading to demineralization. However, if dietary modifications are done, plaque is controlled, fluorides are given, salivation is controlled properly, and there is source of calcium phosphate and fluoride, then this tooth can be remineralized. So our management should involve these factors. We should aim at remineralization of the tooth structure. One, we should prevent, we should not let caries happen. And even if the caries has happened, we should have early diagnosis, and after the early diagnosis we should aim at remineralization. However, if we are not able to control that and the cavitation has occurred, then proper management of the caries should be done. First is methods which can reduce the demineralizing factors. Dietary measures: we should have sugar substitutes like xylitol, sorbitol, aspartame. Fibrous foods should be taken because they increase the salivary flow. They increases the caries protective mechanism because these food contain natural phosphates and non-digestible fibers. They are not sticky. We should not eat sticky food. The alternate is fibrous food. Fats. Fats actually form a protective barrier, and sugars will not stick to the tooth. So fatty food will improve the chances of remineralization. Cheese is considered as responsible for increasing the salivary flow. It increases the pH and it promotes the clearance of sugar. So these were the dietary methods. We can substitute the sugars with the artificial sweeteners, which are non-cariogenic. We can have more of fibrous food. We can have more of fatty food, more of cheese. Methods to improve the oral hygiene: dental prophylaxis, toothbrushing, interdental cleaning with the help of floss or interdental brushes can be done. Various chemical measures can be taken. For example, we can use chlorhexidine, iodine, urea and ammonium compounds, nitrofurans or glutaraldehyde. These actually are the substances which are present in your mouthwashes, and what they do is these are the substances which interfere with the bacterial growth and metabolism. Then there are certain substances which interfere with the carbohydrate degradation, that is vitamin K and sarcoside. Now, methods which increase the protective factors. One, we should methods which decrease the hyposalivation and improve the salivation. For example, the baking soda, the quantity of saliva should be increased, quality should be improved. Then there are certain chemicals which alter the tooth surface, like your fluorides. These form the fluorapatite, and silver nitrate or zinc chloride. How does fluoride affect it? They form the fluorapatite. They inhibit demineralization, increase remineralization, inhibit the bacterial metabolism, and inhibits the plaque formation. Application of remineralizing agents should be done. For example, your calcium phosphates. Use of pits and fissures sealant should be done. If you feel that your sealants, pits and fissures are retentive, they should be sealed then and there. Enamelloplasty is the another option. Which type of pits and fissures are the most retentive, which can lead to severe caries? Types of fissures which are most retentive.
I and U.
K type. K type. Now, advanced methods, which involves genetic modalities. So we can genetically modify our foods. We can give probiotics. Genetically modified organisms. New strain of Streptococcus mutans have been created, which do not ferment the carbohydrate. So lactic acid is not formed, unable to produce lactic acid. Lactobacillus Z. These are genetically modified bacteria which produce actually antibodies against the Streptococcus mutans and kill them. Then caries vaccine. These are only into studies. These actually are many trials have been carried out on the experimental animals in the laboratories, but vaccine such as such is not commercially available. Three routes have been tried. One is the induction of the mucosal immune system by stimulating the production of salivary immunoglobulins A, or the systemic immune system is induced by production of the serum antibodies, or passive immunization through the application of antigen-specific antibodies on the tooth surface against the Streptococcus mutans. Caries vaccines have been tested in animals, but still the commercial availability is not there. Now, there are certain disadvantages. There is great difficulty to produce them at a large scale. Short duration of the experiments in animals, they are not really reliable. Now, this was all about the methods which can prevent the caries, or now if the caries has happened, management, how it should be done. First is air abrasion. Cavity preparation can be done with the help of your air rotor and burr, but there are certain other methods like air abrasion in which you use the kinetic energy of the particles to cut the tooth surface. Mostly aluminium oxides are used. Two sizes are available, 27 micrometers and 50 micrometers. These are more comfortable. However, 50 micrometer sizes are more abrasive. The abrasive particle, they hit the tooth, and the kinetic energy is converted into the cutting energy. Advantages: they are non-traumatic, non-invasive, no microchipping, less discomfort, no anesthesia, and decreased thermal buildup. The disadvantages: lack of tactile sensation, risk of cavity over preparation, spread of aluminium oxide, danger of air emphysema, impaired indirect view, and damage of dental mirrors can occur. So we need to have single-use mirrors. These abrasions can be used for cavity preparation, internal cleaning, microabrasions, or stain removal. Air abrasion is not used in crown preparations, large caries, or amalgam removal. So these were the contraindications. So patient who is allergic, who has asthma, patient who has had fresh extraction, or patient with recent placement of orthodontic appliances, they should not go for air abrasions. Certain precautions to take in mind: both the patient, patient and the clinician should wear the mask. The patient should remove the mask only at the time of the procedure. Use the rubber dam, protective eyeglasses, and metal matrix to protect the adjacent tooth structure, and use disposable mirrors because the mirrors get damaged after one use. So this was a cavitation. Air abrasion nozzle projects the aluminium oxide particles over it. Two sizes are available, 27 and 50 micrometers. Cavitation is done, followed by restoration. Then the ozone therapy. The ozone destroys the bacterial cell membrane, and therefore the bacteria dies. The indications are for primary root caries or primary pit and fissure caries. They mostly kill 99% of the microorganisms, oxidizes the caries, and speeds up the remineralization. They help to remove the organic debris on the carious lesion, potentially whitens the discolored caries, decrease treatment time. Treatment is painless and noiseless. It does not cause any allergic reactions, and microorganisms do not develop resistance to ozone. Chemomechanical caries removal uses Caridex and Carisol. These are the composition. They consist of solution 1 and solution 2. Solution 1 is 1% of hypochlorite, sodium hypochlorite, and solution 2 contains aminobutyric acid, sodium chloride, and sodium hydroxide. Whereas your Carisol, this is in the paste form. Caridex is in the liquid form. Lasers. Lasers, mostly your hard tissue lasers. Erbium biag and erbium chromium bias GG lasers are used. They are projected over the tooth surface, causes the disinfection and disruption of the bacterial membrane, leading to cavity disinfection. They have photomechanical effects. Laser light is highly energetic, and this effect causes the ablation of the tooth. Fast mechanical shock waves are produced, which due to photo vaporization of the water causes the ablation of the dental tissues. Laser application, if you have caries, then 100 to 200 millijoules of the energy is applied. For dentine, 150 to 200, and for enamel, 200 to 250 millijoules of energy is required. Only gently touch the target tissue. Direct water stream is applied to the target tissues because heat is produced. Always keep the operation site wet. Keep the tip moving to provoke the effective ablation. Its photomechanical energy is converted into the ablation energy. For deep cut, move the tip constantly up and down. So pumping action. 1. It does not compromise the pulp. 2. It can remove the caries effectively. It can perform cavity preparation effectively. The quality of the cavity preparation is equivalent to that with the handpiece. There is no patient anxiety. Patient will be pain-free and anesthesia-free. Little or no post-operative defects, and it is ideal for the children and adults. However, one thing that we cannot use it for secondary caries, or if there is some caries beneath the cast restorations. So these were the methods of your management of cavitation: air abrasion, ozone therapy, lasers, chemomechanical methods. So these are the methods, and then various methods to prevent the caries, which involve your dietary modifications, usage of proper oral hygiene practices, and then there are certain recent methods which involve genetically modified ingestion of genetically modified organisms or caries vaccine. So this was about this diagnosis and management, and your caries part is done. Anything you feel like you want me to repeat if I was going fast, or anything you want me to explain again? Any doubts? Scoring part, you need to, there is a bit of cramming in that part. Scores, you need to remember what score will indicate what. Other than that, there is some usual methods of caries management. Any queries? All right then, all the best.
Thank you, ma'am.
Thank you.